in this last 8 to 9 months, we have seen our lives being transformed, both for the general public and as for clinicians. And at this moment of time, I think we should all think about the heroic service that has been provided by the frontline workers, be it doctors, be it policemen, be it even our people who work for the government firms. They have put their lives at stake, and we've managed this. I am predominantly based at Fortis Hospitals, Banagata Road. For those of you who don't know me, I also visit Fortis Nagabavi and Fortis La Femme on a once-a-week basis. My interests are adult cardiology, primary angioplasty, complex devices, heart failure management, both in terms of medical and device therapy, and I have a keen interest in emerging interventional therapies. There are some things that we want to talk about, predominantly talking about the facts about COVID and the heart, how we managed cardiac care in COVID times, both for COVID patients as well as non-COVID patients, and what exactly we are offering at Fortis Hospitals, Banagata Road. That would probably form the last few slides. Now, it's like asking the granny, teaching the granny how to suck eggs. This was new for all of us about 9 months ago, but now I think everyone is an expert about COVID. But it is still important to talk a few words about these things. This was a novel coronavirus, which is no longer novel after about a year. It's an RNA virus which spreads predominantly by droplet infections, and that is the main problem with it. It's a highly contagious virus. Vast majority that we have seen experience mild to moderate respiratory symptoms. A significant number of patients people who've got other comorbidities like diabetes, obesity, hypertension, smoking, COPD, do manifest the higher end of the disease, which manifests predominantly in bad lung problems and cardiac problems. RT-PCR is another technique called Gene Expert, which again is an RT-PCR technique, but we get results quite early. And for the mass screening and antigen testing, and for those who have recovered, we have the antibody testing. Even to this day, although we've got lots of papers coming from here and there is no preventive treatment. There is definitely not any significant targeted therapy, although apart from the good old treatment of intensive care units, that is steroids, there's no other therapy which has consistently shown these kind of good results. What has been the impact of COVID-19? Well, it's had a huge impact in a lot of ways. In terms of the lockdowns, you can see the second wave going in the European countries and the US. They have started their second lockdowns. They have restricted times, restricted movements, both in terms of social distancing, masking, and hand hygiene has become a way of life for all of us. Flipkart, through distance, she had COVID sitting at home. So don't think that you're protected by it. You have to take your precautions as it is. And a lot of people have resorted to cell therapy via Google and have not really linked up with the doctors at the time that they need to, and end up coming with the end complications of it. Weight gain is not surprising, sitting at home, watching all sorts of channels. I think all of us have got bored or nearly cleared up all the movies that's there in Amazon and Netflix. We're looking for newer channels to see if we can pick those up. Gyms being closed has made a huge impact in terms of people not exercising regularly. And everyone thinks he's become a master chef, or she thinks she's become a master chef. And so there's a significant weight gain. Not to forget this important thing of sexual violence. There's a lot of things of this happening, and this is predominantly led to due to the lockdown and breakdown in relationships. So it's important that we talk about these kind of things, because these may not be related to a cardiologist, but we see the impact of that in terms of stress-related hypertensive crisis or even acute myocardial infarctions. So moving on to something which is more central to what I do is cardiac care in COVID times. And I think this is very important. And it really depends upon where you work and how you work. This is my consulting chamber from where I'm sitting at the moment. I have to say that my organization Fortis has been at the forefront of tackling this head on and making sure that the people who are working for Fortis, whether it is being from the support staff to the senior doctors, had made it very mandatory that they would support us, giving us N95 masks on time, ensuring that there is adequate amount of support, both in terms of ensuring people who are at risk or who may be infected being kept away from the main hospital. And this has gone a bit way. This is the picture on the right is what I have been on most days with a N95 mask and a face shield and the two sterilizers on the right and left hand side. And it has really helped. We have moved on, and I think all clinicians have moved on into the technology, accepted the technology, and we have been available for our patients. We have consulted from home, and whether it is from Zoom calls or through the Teams call or through HemFine or through Practo, we are available, and that has made access to doctors quite easy, and it is something which probably has saved quite a few lives or quite a few admissions, if not lives. So it's important that organizations recognize this and support this. These are some of the images, and as I said, Fortis has been at the forefront of treating COVID patients. It is one of the private hospitals which decided that right from the start, we are not going to say no to patients, but we will make the place safe for people who have got non-COVID illness to come in and get their treatment and not be denied the treatment. So one of the key things you can see on the screen is this cute little robot, Mitra and his colleague. And this made national, if not international news. In fact, it even did come in the BBC. This little toy, this little robot asks certain questions, and his partner checks the temperature. And between the two of them, they tally their thoughts. And if someone is turned out to be high risk for COVID infections, they are directed right from the door to the flu clinic, which is positioned outside the hospital. Yeah, we are lucky in that we have got two easily segregated areas. Our COVID wards are one floor, totally segregated from the rest. Our COVID ICU is in the new block of the hospital, which is again protected. Now, when we started off with the COVID, initially we were of the conservative approach that we should try and treat these people with thrombolysis or with optimal medical therapy. But as time passed, we realized that we did not have the choice because we were getting such sick people with COVID as well as acute myocardial infarction. So you could see me and my team prepared taking on the COVID pandemic and so on. This is after one COVID angioplasty. This is me, my scrub nurse, my senior technician, as well as my circulating nurse, all draped and ready to and protecting ourselves at the same time, doing what is right to the patient. So this has been a theme of ours. Me and my colleagues, Dr. Srinivas included, we probably have treated close to around 50 patients with acute coronary syndromes and acute myocardial infarctions, all with protective gear, and I'm pleased to say that none of our team members have been cross-infected just by treating COVID patients. That is the most important thing, is to take your necessary precautions, but at the same time, do what is right for the patient. And doing what is right for the patient still in our case still is primary angioplasty. And this is an age-old slide from Kelly et al. Published in 1993, which clearly shows to you the benefit of primary angioplasty over and above thrombolysis, be it mortality, be it reinfarctions, be it stroke, or a composite of all. So when we have this kind of a data, it is hard to convince ourselves, being interventional cardiologists, that we will give these patients thrombolysis and not primary angioplasty. With that thinking in mind, we as a unit have taken on all these patients, and as to treat them as aggressive as possible. We have got a designated bed allocated in the COVID ICU for any patient who comes in with a myocardial infarction or acute coronary syndrome. So we take them straight to the cath lab. We have no delays. Our teams are all draped and ready. We do the intervention. By the time they come into the cath lab, they would have had their antigen testing done and their gene expert sample taken. By the time we're finished in about 45 minutes, we have the data available. We can then decide whether these patients can come to the conventional non-COVID CCU or go to the COVID ICU. And this has worked out quite well and has helped a lot of patients. When you come to the cardiovascular manifestations of COVID, well, it's predominantly myocardial damage or myocardial injury. The mechanisms can be debated, whether it's inflammation, whether it is cytokine storm, whether it is macro or microemboli, whether it is because of supply demand imbalance. But the key factor in all of these is the evidence of troponin levels. And we know that the lower the troponin levels you have, the better the outcome in terms of hospitalization and in terms of mortality. The higher the troponin levels you have, we know that hospitalization is longer, complications are longer, and mortality is longer. And mortality is higher. So we have a very clear understanding. So most patients, even if they get small amounts of troponin release, are treated with antiplatelets and anticoagulants. We have an excellent team of clinicians, which involves intensive care doctors, pulmonologists, and a dedicated infectious control consultant. They work together, and every patient who requires any kind of intervention or any kind of input from us, we are contacted from the cardiology team and we look after them. Though from a distance, we don't necessarily need to go in unless we have to shift them across for an interventional procedure. And when you talk about the post-COVID status, we initially, when we started off learning about COVID, we all thought that this is like any other viral infection. It is a transient illness, but we now know that from MRI studies that patients' cardiac involvement is seen close to about 70 to 80% of patients following COVID infections. Now, what is the standard? What is the extent of the involvement? Is it just fibrosis? Whether it is affecting long-term in terms of myocardial damage is something that needs to be known and something that needs to be learned in due course. We have still followed the guidelines as illustrated by the European Society of Cardiology way back in 2013. So primary angioplasty is still what we offer all our patients, whether it is COVID patients or non-COVID. And if they are coming after having had lysis, we try and take them through within 4 to 24 hours. And this happens across the board. And that is something that we are proud to say that we do. And we don't wait for any other tests, or we don't delay any of the investigations just because they are COVID positive. Just moving on slightly to some data. This is a 64-year-old lady in the first half of the COVID illness. She's a mother of a cardiac surgeon who happens to be in Canada. She went into a hospital of her choice, or rather the son's choice, with an acute myocardial infarction, went in with pulmonary edema, was sent away from the hospital by the staff saying that she has got COVID illness when all she had was florid pulmonary edema on the chest X-ray. I happened to be involved because a friend of the son, he is a good friend of mine. So she was brought across here, cardiogenic shock, went straight through. As soon as she came in, she had bradycardic episodes. She was electively ventilated, wheeled into the cath lab, underwent a left main angioplasty, had an intra-aortic balloon pump. This elderly lady had an intra-aortic balloon pump, was on a ventilator, conscious all along, and did not move a bit. For 3 days, she was on a ventilator with a balloon pump, recovered well. And my interaction with the son was through video calls and through WhatsApp, sending him pictures of his mother, how she's recovering. Now this is about 6 months. She's now come for about 3 follow-up appointments. She's back home doing her own stuff. And this was one of the early ones that we did. Here is a cohort of patients who were all sick people. The first lady on the top is a widower. Is a widow who's looked after her children from the age of 5. has got about 2 or 3 acres of land in a small town which is outside Bangalore, about 50 kilometers, called Kanakpura. Came in with a cardiogenic shock there, had complete heart block, brought across here. The moment she walked in, we knew that she had COVID. Uh, she had COVID, and she had 3 days of fever and stuff. We took her straight in, stented her, and took her back. The lady in the middle is a lady who has had oncology problems, an old patient of mine who came in again with an acute coronary syndrome. We stabilized her in the COVID ward, brought her across, did her right coronary artery angioplasty. This guy at the bottom is another man. In fact, I saw him yesterday for his second follow-up. Inferior wall MI, complete heart block, brought across here, stented, found to be COVID positive and treated across. So it has been quite a gratifying experience so far. And I'm sure Dr. Srinath, who's treated quite a few of these patients also, has got stories to say, and so would Dr. Gopi. So these are all patients that we've made a difference to their lives. This is non-coronary work. Coronary artery stenting. The one on the right is a 34-year-old lady who had carotid artery disease and who underwent stenting again during the COVID time. This elderly gentleman is a 97-year-old gentleman who had symptomatic carotid artery disease, underwent stenting, and this is him reading the newspaper the following morning. Today, I've done another 75-year-old patient who's a mutual patient of Dr. Gopi and myself, who has got heart failure, bilateral carotid artery disease. We have dealt with one carotid artery stenosis today, and he's doing well. So that is the kind of work that we're doing. This is an elective complex angioplasty, which she went to one of the tertiary centers, which has got 7 cath labs in our city, was told that because of COVID, they're not doing any interventional procedures, came across with ongoing symptoms on and off, CCS class 2 symptoms, kept for 2 days, underwent complex rotablation. She was non-COVID, by the way, and you can see that she went home within 2 days. So we have not denied treatment for non-COVID patients. At the same time, we have made sure that our COVID patients who have been treated are treated well and appropriately. We have been doing a whole range of these interventional procedures. Even in the COVID times, a colleague of mine has done, with Dr. Gopi's support, has done aortic stent grafting, both infrarenal as well as aortic arch stenting. We have done CRT therapies, we have done TAVI procedures, and we have also been supported by management which has not hesitated to invest in the organization or in the hospital. In these times, it has invested in a second cath lab, which is a state-of-art biplane cath lab, which is one of the 2 in South India of this standards. It has increased our cath lab availability. It has ensured that we do not have any acute delays for acute emergencies. And by nature of this being a biplane cath lab, we can provide better imaging modalities and have a low risk of contrast nephropathy, particularly so for complex coronary interventions and non-coronary interventions such as TAVI or carotid artery stenting. In fact, the gentleman today, I have probably saved around 60 to 80 ml of contrast just by using the biplane modality that we have. More so in patients who have got neurointerventions, complex neurointerventions. This is a boon because it gives the interventional radiologist such good imaging modalities that he can do an excellent job with the procedure. We use standard of care technologies. Fractional flow reserve is one of the key things that we use to ensure that we only stent or treat vessels that need to be treated and not vessels which don't need to be. We use this on a regular basis, and this is a very validated technique, as most of you would agree. And this is available at Fortis Banagata Road. We also use intracoronary ultrasound to decide what sort of treatment that we need to give to a particular vessel. We also use it to make sure that the outcome from angioplasty is optimized. We've got the new kid on the block, the optical coherence tomography. This is a light-based technique. This gives very high resolution of imaging techniques, and this really helps. This is just a few images about how good the magnification is. The image at the center is after a balloon angioplasty. You can see the tethering of the neointimal hyperplasia. The one on the right is someone who's got a thrombus. The one on the top left is a well-expanded stent. So these are things that we use. We had the joy of using this. Both Dr. Srinivas Prasad and me worked on this patient who had a focal new lesion in a stent which was 18 months old, in a drug-eluting stent which was 18 months old. We use this technology to first diagnose the condition and ensure that we do the right treatment, and that is something that is being used on a regular basis now. We have a high-end CT scanning, which also enables us to decide, even before we take the patient on the table, what our approach should be in terms of management of these patients. By doing so, we can get to do such complex lesions. The lesion on the left was a totally occluded lesion. Dr. Gopi will recall this. This is the first case Dr. Gopi and me did together, rotablation as well as a tonus catheter. It is now 6 years since this gentleman had his angioplasty, and is doing remarkably well. We are regular users of this technology of rotablation. In fact, yesterday I did one which was about 3.5 hours, but managed to open that heavily calcified LAD in a 46-year-old diabetic lady. We've moved on from just coronary work, and this is probably going to be the mainstay of our management in the coming 3 to 4 years' time once the prices of the technology come down. Aortic stenosis is no longer a surgical disease. It is a degenerative disease that we predominantly treat. And we know that once an aortic stenotic becomes symptomatic, he's got limited time. So this is something which should not be ignored. And we also know that particularly in the elderly patients or patients who have intermediate risk, surgery is a scary thing. So we've moved on from management of that into transcatheter aortic valve replacement. Both the Cunningham Road and Fortis Banagher Road have got a good experience of transcatheter aortic valve replacements, whether it is balloon expandable valves or whether it is self-expanding valves. We have got experience in both. This is one of the state-of-art valves which has got a lot of experience behind it. This is the core valve. We also have the Indian valve, which is known as the My valve. We've got experience in both of these. And these are all percutaneous techniques which are easily available. And even in these COVID times, we have managed to deal with all these. This is an elderly gentleman, a 73-year-old gentleman who had severe aortic stenosis, who has a patent graft, who underwent a transcatheter aortic valve replacement. This is with the balloon expandable valve. And you can see the valve sitting in quite comfortably without any major issues. This is the team, and it is a team approach. It is not one person doing it. We've got a cardiologist, we've got cardiac surgeons, we've got anesthetists looking after. This is a recent one from just about 3 weeks ago, where we did another 72-year-old gentleman who also had previous CABG and severe aortic stenosis. We've been proud to use the Indian valves, and they've all done remarkably well. And this is all done through this tiny keyhole puncture in the right groin, which has been secured with only 2 sutures. And this is the man 3 days after he had a major valve replacement, such as transcatheter aortic valve replacement, went home. So a lot of things have been happening. Heart failure therapy is progressing. We are running the heart failure clinic on a regular basis, and none of these has stopped in terms just because it is COVID. So ladies and gentlemen, in summary, I would say that cardiac issues contribute about 30% of the complications of associated with COVID illness. Cardiac care in Fortis Banagher Road as well as in Fortis hospitals across the city is very well streamlined and is evidence-based. And for us, the arrival of the second cath lab has really made a huge difference in that we can provide better quality care, and we can undertake complex device therapies, both whether it's coronary or non-coronary. Thank you very much for your patient hearing, and I will stop here and take any questions if there are. Thank you.
Thank you, sir. That was really nice talk and nice summary of what we do at Fortis Banagher Road.
Thank you.
So before we move on to the questions from the participants, I'll have a question for you, sir. So do you think there is a lot of delay from the patient end in seeking an acute cardiac care? If that is so, have you started seeing some increase in post-MI complications because of delayed presentation?
Sorry, Srinivas, I missed that. My apologies.
Okay.
It was not very.
Yes, my question was, do you think that there was a delay from the patient side in seeking an acute cardiac care, especially with those with the chest pains? And if at all, if you had seen a lot of late MIs coming in or late presentation of MIs, have you started seeing any increase in mechanical complications after these MIs?
In terms of the COVID patients,
Yes. Or
I think
COVID as well as a non-COVID because of the
I think
lockdown.
initially they did, and I think in the first 3 months when there was a big scare, people refused to come out, and we did see quite a few of these patients coming in with end organ damage of severe LV dysfunction. There were a couple of free wall ruptures also that came into the hospital. But I think with the passage of time, with the confidence that people have developed, and thanks to our hospital, which has highlighted the safety issues that they've taken into consideration, we are seeing a lot more patients coming in early. I think most of the COVID patients that we've seen, at least the ones I've treated, every single one of them has gone home alive and is keeping well. And I think that's because we have treated them for what they are, not because of the concomitant COVID illness.
I think that's a fantastic achievement as well. And that's
Yeah, I
a
think it
lot
is. Yeah,
about the organization as well.
yeah, it does. It does. Yeah, yeah.
I think let's look out for some questions. If there's some questions, let's take it. Okay. So I think there are no questions set. So just because we started late and there's a want of time, let's move on to the next topic. And then if there's further question, we can take it up at the end, sir.
Thank you so much. Thank you.
Thank you, sir. So the next topic is about advances in intervention cardiology, about the CHIP program. This talk will be by Dr. Gopi, as I introduced him. So he's a director and senior intervention cardiologist at Fortis Hospital, Cunningham Road. We know that in the last few years, intervention cardiology has grown in leaps and bounds. The fields of coronary intervention and structural heart disease intervention has grown a lot. The coronary interventions has seen what is called as a development of CHIP protocol. CHIP actually stands for coronary coronary high risk intervention in indicated patients or a coronary high risk interventional program. This basically involves managing higher risk and sicker patients and attempting intervention on a more complex anatomies. Similarly, structural heart disease interventions for aortic stenosis, mitral stenosis, and degenerated bioprosthetic valves have seen a lot of improvement and a lot of popularity now. And Dr. Gopi is going to talk about all these things, and let's see how he's going to take us into this topic and teach us out. Over to you, sir.
Dr. Gopi, we can't hear you. You're muted.
Yeah, sorry. Yeah. So good evening, everybody. So I'm going to talk on recent advances in interventional cardiology, probably touch upon the CHIP program and also a current status of all the other interventions. To try and make it brief, actually, Dr. Rajpal has shown a lot of the CHIP work that is being done in our hospitals in his experience over the last few months during COVID time. So I just need to expand upon that. Now, we know that in Dr. Andreas Grunzig in 1977 did the first coronary angioplasty. Though there was some amount of pediatric work that was happening before that, it was since after the work by Andreas Grunzig that interventional cardiology sort of exploded. So just a little bit about how this whole thing started. I think Dr. Grunzig was very interested in doing vascular work, and he had already developed balloons and started doing the procedures for peripheral arteries. Then it was his dream to do the same thing for the coronary arteries. So he found an appropriate candidate who had a very discrete coronary artery. There was a change in his sort of methodology. Most of the times we look at who are very, very sick patients and who have no other option, and then do a newer therapy. But he worked the other way around. He established modality of treatment and offered this treatment to them. So he had actually there is an interview by the patient himself, which I listened to the day prior to the procedure, when he was posted for a bypass. Dr. Grunzig spoke to him and told him that, explained what the procedure was, told him that you're going to be the first person in the world to get it done if you are ready for it, and we think that you would do well with it. I think he, being a very pragmatic person, understood the benefits of it, and agreed for the procedure. Not only that, I think his whole team was good. He had a surgeon who was very forthcoming and agreed to bail him out in case there was a problem. And that is how the first angioplasty was done. You can see a discrete lesion in the LAD over here. This is post angioplasty, and after 30 years, this patient had an angioplasty for another vessel, and this looked as pristine as what it looked now. So following that, there has been a explosion in terms of procedures that were done gradually. It started with coronaries, then complex coronaries, now structural valve heart disease. In 2018, from the Indian data, it shows that we had more than 4 lakhs interventions that were done, of which probably around 15,000 were structural heart disease and pediatric interventions. The rest of them all being coronary. So that is the extent by which the therapy has progressed. So now, when we look at the current status, there are different things we could talk about. What are the benefits of these patients, and how has advancement in technology helped the therapy to grow so much? Then certain things like access sites, different lesions, they're all things that have progressed and made these complex things possible. Now, in terms of benefit, in stable ischemic heart disease, we do know that it is very well proven to give symptomatic benefit to these patients, probably not in terms of mortality. But when it comes to ACS, we know that in terms of reducing mortality, in terms of symptoms, it is the treatment of choice. And because of this has progressed rapidly, there are not too much ambiguity in the role of interventions in ACS. Because what has made these possible compared to what was being used by Grunzig in 1977, the balloons have become far more sleek, far more trackable, far more pushable. You have a number of different types of coronary wires for different lesions and imaging modalities. So the improvement in hardware has played a major role in this becoming a significant therapy for our patients. Then with once the more complex cases were being addressed to, then there were certain issues, like we had an issue of bleeding. So for which access site, with femoral artery, we found that access site bleedings were much more, so which radial artery was started to use. So these are all the factors that have been responsible to improve this modality of treatment in such a tremendous way. So if you look at after the balloon angioplasty had become popular, then the concept of stenting came, and this was the first article that came out in 1992, intracoronary stenting for acute and threatened closure complicating PTCAs. So this article changed the rules. So after an angioplasty was done, it was possible for us to be much more let us say calm. We were able to handle some of the complications that were associated with angioplasty, and both the patient and the doctor were much more calmer and much more safer once stenting was introduced. If you look at how it is in 1977, the plain balloon angioplasty was introduced. Then in 87, bare metal stents, so acute emergencies were taken care of to a large extent. In 2003, when DES, drug-eluting stents, were introduced, the restenosis rates got impacted in a significant way. And then following that, we were not able to completely take care of restenosis. The newer modalities are being tried, thinner stent, thinner struts, without polymer. So this fully absorbable stent. So these are all the ways different technology has been progressing and trying to make the procedure much more safer, more durable, and to allow more patients to undergo this treatment. So here you see the stents that have come in. The thickness of the stent struts have progressively reduced. Now you have the Synergy or the one more stent which has got a 0.06 mm thickness, which is the thinnest strut, that is by Biotronic. So the struts have become thinner. Now they've started having, finally bioabsorbable polymers. The absorbed stent came into the market, underwent, I think almost for 3-4 years it was used. Then we did find that there were some restenosis issues with it. got off the market. Still a lot of work is going on to try to bring about these stents back into practice. Now, the next is unfavorable coronary anatomy. So to start off with, it was always just discrete lesions, short lesions, non-calcific lesions. But with improvement in skills of doctors, improvement in the hardware, we have started doing much more complex lesions. This is where the CHIP program, where you have high-risk bifurcation lesions, chronic total occlusions, which are 5 years, 10 years, 15 years documented chronic total occlusions, LMCA lesions, protected, unprotected, calcific lesions. So all these lesions have now come under the armamentarium of angioplasty. It is possible for us to do a safe angioplasty in most of these patients, as a result of which indications for surgery have come down. I still wouldn't say that both these modalities of treatment are competing for the same patient, but the role of angioplasty has expanded to lesions which we thought would not be possible in the past. So not only these, we have patients who are sick patients. So supported angioplasties. It could be IABP. Now we have the Impella device. You have the ECMO. So all these supports have made it possible for us to undertake patients who are very, very sick, extremely high risk for surgery, and these patients can be now subjected to very relatively safe and successful angioplasties, and that is what CHIP program is all about. We'll show you certain examples of some of these complex lesions, and then we'll move forward to some structural heart diseases. So this is a bifurcation, a very complex bifurcation lesion. In the early days, probably these were lesions where we would not want to do an angioplasty for this, but today we are quite comfortable doing this. And here we have done what's called the provisional stenting. We have stented the main vessel, because I think a lot of studies show that a single stent strategy is the best, but may not be feasible at all times. And when we have the armamentarium, we are confident of doing these patients and then getting away with a single stent. Now, this is another patient in whom had a complex bifurcation lesion, and here also we find that the LAD is totally occluded, a very huge diagonal artery. In this, it was quite obvious that we would not be able to just do a single stent strategy, and went ahead and did a culotte stenting, a double stent, with an excellent result. And we expect that these patients would have good long-term outcomes. Again, another a bifurcation stenting lesion, both large vessels, both definitely narrowed. Thought that a single stent strategy would probably not be appropriate, and went ahead and did something called a DK crush technique, and we can see that the end result appears to be very good and acceptable. Now, chronic total occlusions have always been a challenge, and that is what, like, the final frontier when we say in terms of interventional cardiology. So this is a post-operative patient who had a long occlusion from the origin of the RCA to the to the PDA bifurcation. And with the technology that we have in terms of different microcatheters, different sets of wires, we can upgrade the wires, and we are able to get such sort of results where you find that you have such a beautiful right coronary artery. And this is the type of procedures that which we think are complex procedures which we have the confidence of doing at this point of time. Then unprotected left main. This is an 85-year-old male who came to us with the class 3 angina, and did an angiogram, had a critical left main stenosis, and it was a left dominant system. So the thing that always surgery would have a chance in these patients, so plan for surgery. But unfortunately, this patient, we also found out this patient had a CA prostate, and hence the decision changed to doing a coronary angioplasty. So we were able to do this without even any support. We sort of kept everything standby in case that there is a problem, and we were able to successfully do an angioplasty. So you pre-dilated, use an IVUS to know the exact sizing of the stent, which gives us, make sure that we do a perfect procedure. And this is the end result that we had, with a normal looking left main, and patient doing comfortably well, discharged on the third post procedure day. Then now calcific lesions has always been a problem, So the lot of calcium, at times we are not able to take the material that we need across the lesions, and we don't get proper deployment of the stent. Expansion, under expansion are there. So there are different strategies that are there that we use today. We have something called the scoring balloon. Then we have a cutting balloon. We have a rotablator. I think Dr. Rajpal just spoke to you about the case that he did. And the new kid on the block is the intravascular lithotripsy. So this is an ultrasound based balloon, which ultrasound pulses are given, and we are able to expand these dilatable calcific lesions with intravascular lithotripsy. So this has made the amount of cases that we can do with an angioplasty much more than what it was in the past. Then to add to this, to again make our job better and to make sure that we are able to do better jobs, we have this intravascular imaging and physiological assessment of stenosis, FFR, where the pressure proximal and distal to the lesion is we are able to measure it, and we know that below, if it stays above 0.8, these patients are people who would do well with medical management, and FFR is now become a standard assessment tool to decide whether this patient is going to benefit from angioplasty or could we leave this patient on medical management, because we know in stable ischemic heart disease still there's a significant role for medical management. So FFR has helped us to decide who are the patients who could be left safely on medical management and who need to be addressed to with an angioplasty. IVUS and OCT, other things that are there. IVUS is again a wonderful tool, been there for a long period of time, helps us to understand the plaque and based on that take decisions regarding what sort of treatment we need to do, and also help us assess the sizing of the stent, whether the stent is well opposed. So based on that, we have different things like fibrous, fibrocalcific, calcific, attenuated plaques, and thrombus. So this is showing a fibrous plaque with an IVUS run over here. We can see a fibrous plaque coming in over there with a narrow lumen. So this we know what sort of strategy. We are not going to have too much of difficulty in expanding the stent and deploying the stent. This is a fibrocalcific. You see, thing is, ultrasound doesn't go beyond calcium, so you get a see over here. You find that there is what is a black patch over here because of the ultrasound doesn't go past the calcium. So we can assess this. Then you have, this is just showing you where the calcium is. You have a very high calcific plaque over here. Then you can decide, classify the calcium. Is it a deep calcium? Is it superficial calcium? Based on that. The next is something called attenuated plaque, where it is rich in lipids. So in this patient, we know that if we do a very aggressive dilatation, these are patients who will have slow flow phenomenon. So we need to be certain as to what strategy go on a low pressure dilatation. So we can decide on what strategy would be best for this patient. If there's a lot of calcium, this patient needs rotablator, this patient needs IVL, this patient needs a cutting balloon. All these decisions can be done based on the characteristics of the plaque. Then we can assess the sizing of the stent. What is the lumen area? What is the cross-sectional area? And after that, as the stent being deployed properly, these are the different ways by which the IVUS helps us. So complex angioplasties, we always want to make sure that the failure rates are lesser, because you may not get a second chance to tackle these patients. The next one is the IVUS. I mean the OCT. Again, this is a pre-OCT run. Here again, we can assess the size of the vessels. We can assess the amount of calcium, thrombus, stent deployment. So this is a case where we do a pre-assessment, and after stenting, we again assess this. Yeah, you can see the lumen, and you can make out the characteristics of the plaque. Then after we do the stenting, we can see the stents and see how well the stent is deployed, and make sure that we do not leave any under deployed stent or under expanded stent, thus giving rise to a much better clinical outcome. So this is again the same things. We have still pictures. We have identified which areas we want to take a better look at, and both pre and post. Then again, we have the option of something like a fly through, where we can see a 3D image, and again look at our deployment. Has it happened the way we would want it? and optimize it in a much better way in a given situation. So this is how OCT IVUS has changed our practice and helped us to get better outcomes in more complex patients. So once we have the coronary, so this is what is the coronary. Then when you come to the non-coronary interventions, we can broadly classify them into the either closure of defects, fistulas, opening up of valves or obstructions, and then the other interventions. So these all come under structural heart interventions or non-coronary interventions. They have also progressively evolved with coronary interventions. Now, the most dramatic one that has sort of happened is the transcatheter aortic valve replacement. Because in 1989, the Danish researcher Anderson developed and tested balloon expandable valve in animals. Then it started. We started using it in humans, but found that in the elderly, the balloon expandable balloon valvuloplasty really did not give us too much of long-term result, and we knew that we needed something to actually a new valve inside. So it was in 2002, April 16, that Dr. Alain Cribier in France first implanted a transcatheter aortic valve. It was a very sick patient, cardiogenic shock. They'd done a valvuloplasty, no improvement, continued to be in shock. He crudely made, but transcatheter valve was deployed in an antegrade manner, that they did a septal puncture, 24 French, and they managed to deploy the valve. This patient came out of the shock, survived for almost 17 weeks, and died of septic shocks due to some other reason. That was the starting of transcatheter aortic valve, and since then it has rapidly progressed. I think after getting the FDA approval in the first 2 years, almost 20,000 cases were done in the US. In the first 5 years of getting a CE approval, almost 35 to 38,000 cases were done in the Europe. At present, it's become treatment of choice for the elderly, for patients who are high risk for surgery, patients who are intermediate risk, and to the extent that they've started using it even for low risk patients with acceptable results comparable to that of surgical aortic valve replacement. The core valve from Medtronic got the CE mark in 2004, and the FDA approved the Edwards Sapien, it's a balloon expandable valve, in 2007. So here you can see the balloon expandable valve and the self-expanding valve post-deployment. Now, again, in terms of valve therapy, we had the balloon mitral valvotomy to start off with for mitral stenosis. Then came the percutaneous annular repairs, and now you have the mitral valve repair by using the mitra clip. And also, even we have a transcatheter mitral valve replacement, especially people who have a already existing bioprosthetic valve or have a very calcific mitral annulus. In them, a percutaneous mitral valve has become a reality. Now, this is a 80-year-old male who came with severe aortic stenosis. It's almost been, I think, 5 years since I've done this. So this was one of our initial TAVI cases. So you had a calcific valve with significant aortic stenosis. We didn't predilate it. We took in a valve. This is the core valve at that point, a self-expanding valve, positioned it appropriately, and so this is the procedure, the deployment that is being done. We can deploy it halfway, reassess the position, and then gradually deploy it completely. So this is a deployed valve, showing that there is hardly any aortic regurgitation with a well-deployed valve. It's been almost 5 to 6 years for now, and the patient is doing extremely well. The newer valves are better. We are able to recapture the valves if we think the position is not too good, thus making it much more safer and more easier implantable. So here, showing the pre-procedure gradient between the LV and the aorta, and post-procedure we see that there is no gradient at all. The next you have, this is the percutaneous balloon mitral valvotomy being done for mitral stenosis. Not really recent, but yes, I think the starting of valve interventions, treatment of choice for all patients who have a suitable mitral valve is balloon mitral valvotomy, and we have excellent long-term results. So you do a septal puncture, get into the left atrium, pass the balloon into the LV, and we can see this INOV balloon, which made life so much more easier compared to using the regular balloons in the past. And this is a 60-year-old lady who had undergone a dual double valve replacement about 10 years back, came to us with a significant amount of degeneration in the mitral valve, and this patient was scheduled for a redo mitral valve surgery. Suddenly had florid pulmonary edema in cardiogenic shock, and we had to intubate the patient. Pressures continued to be low, and we had to put the patient on an ECMO. So once we did this, we were stuck. We knew that the surgeons were not really keen on operating because patient is heparinized, patient is very sick, patient's liver function had deteriorated, patient's renal function had deteriorated. The only option appeared to be doing a percutaneous mitral valve procedure. So here we have entered into the left atrium. I think that I'm not able to get that going. So once we have entered it, we take a wire into the mitral valve, and we first do a dilatation with the mitral valve and also the septum. This is the septum being dilated. Prior to that, we have dilated the regenerated mitral valve. And once that is done, the next step would be to deploy the percutaneous valve. So this is the valve being deployed. A my valve, 26 mm my valve was deployed. And of course, since the patient was very sick, the patient continued to be on ECMO for about 48 hours, extubated after 5 days. Patient still recovering, with a lot of critical care neuropathy, but on the road to recovery. So if without this percutaneous procedure, this patient would not have made it. And thankfully, we were able to get this patient out of this crisis. Now, other structural heart disease things, you have the left atrial appendage device, which is used in patients who are high risk for bleeding and who need to be on oral anticoagulations. You have the Watchman device, the Amplatzer device that are used. And with these newer complex procedures, we expect that in years to come, there's going to be increased in the amount of TAVI that are being done, increase in left atrial appendage closures, percutaneous mitral valve repairs, hybrid reevacuation are all going to increase with time and people who are presently not suitable for anything will get such therapies. Then in the congenital heart disease, I think we know that today for many of the congenital, like for aortic, for atrial septal defect, the treatment of choice is percutaneous closure, and surgery is generally limited to patients whom we think are not suitable without a rhythm. So this is a device that is being taken across into the heart. So we have a sheet which is kept in the left atrium, and that is the device that is being deployed. And then once the device is deployed, we sort of check the position. We are happy with the position, be it on echocardiography and on the floor, we are happy with the position. Then we are ready to release the device. So again, different positions, and once we are happy with it, as we unscrew the device, it will. Yeah, now we have the device has been unscrewed, and this is now the standard procedure for all patients who come to us with atrial septal defect, unless there's a specific reason for us to send this patient for surgery. So patients are admitted in the morning. In the second half, we can do the procedure. Next day, the patients go home. So this is the final, picture with the device in situ. Then other congenital heart disease, you have here a young male, hypertension with a severe, coarctation of the aorta. And initially, we used to do a plain balloon, but now we know that having a stent has made things much more safer and much more acceptable. So this is a patient who came to us, and we are stenting this patient. Patient's blood pressures became normal, with doing well on follow-up as such. This is the final picture after the stent has been deployed. Yeah, I think so. This is something issue here. So this is the final picture in this patient. Then other peripheral vessel disease. You have here a patient who came with a gangrene in the great toe. On investigation found to have a very critical aortic stenosis infrarenal, and here we find that we have done a stenting for this. I think Dr. Rajpal mentioned to you about when you have aneurysms, we are able to do the similar thing and put in a stent graft. Now, this is a patient with a carotid artery stenosis, an elderly male, 80-year-old male who came to us post aortic valve replacement, had a lesion. Now, of course, surgery and angioplasty are options, but this is a patient in whom even surgeries, surgeons are not happy to do it because much higher up. Again, with the stenting, we have got an acceptable result over here. So these are the whole armamentarium of coronary intervention that we have shown. Of course, I have not been able to show each and every intervention in detail, but today interventional cardiology has grown in leaps and bounds, and we have been able to make a difference in all the areas. These things have been happening even during COVID times. Many of these patients were done during COVID times, and the precautions that which Dr. Rajpal has already mentioned to you about, we have done this. And as what Dr. Rajpal said, even in our team also, none of us have, we keep our fingers crossed, so far been safe. We have not cross-infected anybody. And, I think the organization has supported us with this. And this probably a part of it is going to become the new normal, because we do not know when this is going to go away. So this precaution that we take and so help our patients to get better results. And we want the patients to get away from the fear that these things are not possible at this point of time, and it is still possible for us to get a good result and get treated for these conditions. So things have changed in interventional cardiology. Like, you look, this is MG Road, what it was in the 70s, then in the 90s, and in the present era. So everything is always changing, becoming more advanced. Similar way, I think interventional cardiology has kept pace with the time and reached what we say is unimaginable, probably, but I'm sure visionaries like Grunzig would have already had visions of this when he started off his program. So thank you for your attention. And if there are any questions, I think I'll be happy to answer them.
Wonderful.
Thank you, sir. Wonderful talk. Actually, you took us through an evolution of coronary interventions from POVA to almost complex, highly indicated complex interventions like CHIP programs like CTO, bifurcations, image guided and physiology, and similarly in the valve from a simple BME to transcutaneous mitral valve replacement. Fantastic, sir, and well illustrated cases as well. So one question from my end. So most of the Indians do develop this coronary artery disease a decade earlier compared to our Western parts. And a decade earlier, most of our primary mode of therapy used to be a surgery rather than intervention. And some of them have been kept on a medical follow-ups from our surgical colleagues because it was an highly complex case and surgically may not have achieved a good results. Do you think all these patients are coming back and are in a stage of needing an intervention? And this is where the chip is growing up in India?
Yeah, definitely. See, what we thought was not possible in the past is possible at present. I told you, for all the different technologies that have come, and I think at present supported and PCIs with the advent of Impella. Only thing is so exorbitantly costly. I think if we are able to get the cost down, I'm sure a lot of our patients whom we have surgically rejected patients will definitely be able to come. See, thing is, you can work patiently on the patient, not being too worried about what is happening to the cardiac output, and I think that makes life so much more easier. I hope that in the years to come, we'll be able to bring down the cost of the Impella, and because there are so many young patients who are following up, diffuse disease, not suitable for surgery, and still surviving. So if we can give them, a better blood flow, we can improve their quality of life, and hopefully, I'm sure with a severe triple vessel disease, I'm sure we'll have an impact on mortality also in these cases. Yeah.
Very true, sir. And especially with hybrid revascularization catching up, I think we should do a better job in conjunction with our surgeons. What do you think, sir? How much is your practice of hybrid revascularization in your day-to-day practice?
I think, see, the truth is that hybrid is not really taken off. Again, there are reasons for it. I've had probably just a handful of patients who have undergone surgery followed by a intervention in the same sitting. I think it will going to take some more time for our patients to accept the fact that they need to do surgery and they need to do an angioplasty. complex angioplasty for a patient who's rejected by surgeons is probably far more acceptable rather than a patient telling, I pay so much for this and then again for this. So I think that thing probably in time to come, if we are able to make our patients understand why we do that, it will have a future. But at present, I think what we think, the surgeon cannot get it. If it's something, okay, leave it, and then they will manage. That is how it is. But I think hybrid revascularization is going to take some more time for us to mature into that stage. Yeah.
Very true, sir. Probably one of the areas where probably most of us practice hybrid revascularization is if patient comes with an inferior wall MI as an RC as a culprit and also as a significant LAD or LMC lesion. We can do a culprit vessel and then send them for a Lima to LAD graft. And
but I think with our present state of expertise in angioplasties, most of the time I think you do the inferior wall and then maybe a few days later you do the left. So it gives us an excuse not to send the patient for surgery. Actually,
exactly. That's how we.
So I think that has become an issue. I think. Yeah.
But one of the ways like to improve hybrid vascularization.
Yeah, I guess. Yeah, definitely. Yeah.
Team approach, a hard team approach is what is required, particularly with these complexities.
I really think a hard team approach is very, very important. But the only thing is we need everybody on the table with the same agenda.
Exactly.
You can't have different agendas and be on the same table. We will not be doing what is best for the patient. So I think hard team approach is the way. Hopefully all of us will mature with time and get onto the table with what we think is the most appropriate as such. Yeah.
Very good, sir. Nice, sir. Nice, wonderful talk. So thank you, both of you. So Dr. Sir and Dr. Gopi, very wonderful talk. I had a nice learning. I'm sure my audiences also would have had a nice learning. Thank you all. And
thank you for this coordination. Have a lovely evening. Thanks.
Yeah. Bye.
Bye. Bye. Bye. Bye.